Welcome to the Community Living Education Project's Epilepsy and Intellectual and/or Developmental Disability Learning Series. Today's webinar is being presented by Dr. Kate Labiner, Pediatric Neurologist at Child Neurology Consultants of Austin, part of Pediatrix. During today's presentation, Dr. Labiner will share information on seizure rescue therapies, seizure action plans, and seizure first aid. We will allow for time for question and answers at the end of today's presentation. The series is being provided in collaboration with Epilepsy Alliance America and their members. Lisa, would you like to take a few moments to introduce yourself and Epilepsy Alliance America?
Sure. Thank you so much. And we're so excited to be partnering on this webinar series with our partners at Rutgers School of Health. My name is Lisa Gallipoli. I'm the Chief Operating Officer of Epilepsy Alliance America, and we're a collaborative of 17 organizations across the country who provide boots on the ground programs and services for people with epilepsy and those people who care for them. And we were so excited when Rutgers came to us and wanted to partner on this webinar series, because one of the resources that you'll see at the end of the training and that we'll send out to participants is a link to our seizure recognition and first aid training for school personnel, which dovetails beautifully into this webinar today, that we produced in conjunction with the Rutgers School of Public Health 2 years ago, and more than 15,000 people across the country have taken this on-demand training. So we're really happy to have that as an additional resource for all of you after this training, and really excited to have Dr. Labiner present today. Dr. Labiner was introduced to Epilepsy Alliance America through one of our 17 member organizations, Sophie's Journey, which is an organization that's based out in California that provides a 2-day expo at Disneyland each November, a free education and expo for people with epilepsy and their families, and then a 1-day Epilepsy Awareness Day at Disneyland. Epilepsy Alliance America is proud to be a national partner of that event, and proud and happy that that's how we met Dr. Labiner, who you'll be hearing from today. So thank you so much from Epilepsy Alliance America.
Lisa, thank you so much. And as Lisa shared, my name is Melanie McGackin, and I am representing the Rutgers Community Living Education Project, also known as CLEP. CLEP is a program through the Rutgers University School of Public Health. The CLEP team is committed to providing individual guidance, mentoring, and resources regarding the possibilities in community living for people with intellectual and/or developmental disabilities living in the state of New Jersey. The CLEP team member contact information is on your screen, so please feel free to contact us for additional information or support when you or someone you know is ready to explore community living options. Before we get started, let's go over how you can best participate during today's session. To ensure the highest sound quality possible, all attendees will be muted during today's event. To interact with the host or presenters, please use the Q&A option on your screen. And we recognize that we learn from each other. So if you have a great resource to offer, please feel free to share your ideas in the chat section of the Zoom control panel. At this time, I'm happy to welcome today's presenter, Dr. Kate Labiner. Welcome.
Hi, everyone. I'm Kate Labiner, and I am a pediatric neurologist at Child Neurology Consultants of Austin in Austin, Texas. And thank you so much for inviting me to be a part of this series. I appreciate both the Epilepsy Alliance and Rutgers School of Public Health being involved in this project, because this is one of my kind of passion projects of reaching out and helping. In Texas, most recently, a couple of years ago, we passed a law called Sammy's Law, which was puts into place the ability and actually mandates that teachers be trained in seizure first aid and seizure rescue therapies. And that was something that was really important to us because we knew that as families, you are sending your kids to school, sending them out into the world, and we want to make sure that everybody knows what to do. Because unfortunately, a lot of people learn what to do during a seizure when they call 911 for the first time and have a 911 operator walk them through it. So today we're going to talk about the therapies, seizure action plans, and then some basic seizure first aid. A lot of what you will see today is available through the Epilepsy Foundation of America. The Epilepsy Alliance has the same types of resources as well. And then also we are happy to provide any of those resources for you if you want any of the blank forms that we have, or even the forms talking about seizure first aid, just in terms of what people can do given what happens during a seizure and kind of how best to approach that. Right. So what is a seizure action plan? I think that this is a really big thing, that if you have someone who has had seizures from the time they were quite young, you may be very familiar with this. This is the plan that the schools always ask for, the school nurses are always asking for, saying, hey, what are we supposed to do when a seizure happens? But we use them in a lot of other places as well. And I think that that is one of the times that we can see that they can very much be used in places like the workplace, in group home type settings, in day programs. And those are the places that may not naturally ask for one of these because they're not going to be as well versed in what to do. So what is it at its baseline is a plan for what someone should do if a seizure is to happen. It's going to help organize all the information about the patient's seizures, and is going to contain information like, what is their medical history? Do they have an epilepsy syndrome? What seizure types do they have? The frequency of those seizure types, and then also how long they typically last. This is vitally important for a lot of our patients because they may have more than one seizure type, and there may be different things to do based on which seizure type they have. They'll also be on there a space for the medications that are available for emergencies. So if they were to have a prolonged seizure or a cluster of seizures, what do they have, and when and how would we best use those medication options? And we're going to go through the options today. Again, at the end of this presentation, that's kind of the last section, the different parts. I'm also going to give some examples of the types of information that can be important, especially if you've had a surgical intervention for your epilepsy. So if you have a VNS placed, which is a vagus nerve stimulator, that is going to be important to put on there, as well as if you were to have an RNS, or responsive neurostimulator, which are up here. Those are also important information for people to know, so that they'll know how to use those. We'll go through that as well. There we go. We'll also kind of review the epileptic first aid. The most important thing to do is to stay calm, remain with the person. If they have food or fluid in their mouths, you're going to roll them on their side immediately. Keep them safe and protect them from injury. I feel like I've missed a slide. Hold on, guys. I'm going to come out of my slide set really fast and see, because it feels like we missed one, but we didn't. Okay, just making sure. Okay. Oop. Now I advanced too quickly. You're going to keep them safe and protect them from injury. This is most important when we talk about protecting people from head injuries in specific. When you're having large convulsive events, you're going to be moving, jerking, and that can often involve turning of the head or forceful turning of the head like this in a kind of jerking motion. If someone's on the ground, we want to best protect their head and then be able to slide something underneath them. So place something underneath their head if possible. Loosen tight clothing. This is especially important around the neck. So if you're in a business setting, you want to be able to loosen the tie, unbutton the collar, things of that nature that can allow people then to get good movement in the neck and good air movement. If they were having both then constriction of their chest or of their neck, you can imagine that might be harder. And in the setting of a seizure, they're already going to be more challenged in that setting. And then you want to reassure the person as they recover. I always say reassurance is as much for the person having the seizure as it is for the people who are helping them through the seizure. We want to make sure that everyone is feeling better as they come through the seizure. It's a nice reminder to us as we're reassuring someone else that everything's okay, and that they are going to be okay. A lot of patients will tell us later that even though they may still be seizing intermittently, a lot of the end of the seizures will see the jerking intermittently and that it will slowly slow down, that they can actually hear during those even if they can't respond to you, and that they therefore can feel reassured even though they may not be responding to you. So seizure action plans, they come in many different forms and many different ways. We're going to go over a couple different versions of them just so that if you see different options, you'll kind of know what they look like. This one is what to do during it with pictures. I will say this is not the one we use in our office, nor is it the one by the Epilepsy Foundation, but I have seen this one come from multiple school groups. And so it kind of walks people through what they may look like. So if you look here, and I'm going to zoom in a little bit so that we can see it, it actually tells them what the seizure might look like. So if they have an atonic seizure, that's a drop seizure, they're just going to fall straight down. And absent seizures used to be called petit mals. We don't call them that anymore. But those are the ones where people stare, they pause what they're doing. They may have some movements of the mouth, rapid blinking of the eyes, sometimes some small movements of the hands, and then they'll go right back to what they're saying. Oftentimes we see these most frequently in small children, elementary school age kids, and those are going to be the kids and oftentimes picked up first by the teachers. And so we want the teachers to know if they have that type. Tonic seizures are going to be the ones where people get super, super stiff. So they're going to have complete stiffening of their arms and legs. You may see them go off to one side during the seizure. All of those would be part of a tonic seizure. Same if you see turning of the head that gets forced into one direction. Clonic seizures are the ones more like the ones that we see on TV. Those are the ones where you see the nice jerking. These are the ones that are the tonic-clonic seizures, which is a combination of the two. I like to call those the as seen on TV seizures because those are the ones most people think about when we talk about what is a seizure, what does a seizure look like. There are also what we call focal with impaired awareness. And those are going to be seizures where part of the brain is seizing, but the person may look very much awake. They may be able to respond to you. I have one patient personally who is actually able to follow complex tasks, but is unable to speak during his. And so he doesn't always remember the entire event. Some of them will remember the entire event, and those would be without impaired awareness. But that can very much confuse people when they see that for the first time, especially in a setting where they may have only seen the large convulsive events before, because they are looking at someone going, well, they're responding to me, so how could that be a seizure? Because the ones we always see on TV are the large, big convulsive events. So it's very important to go through what is the seizure pattern. Also, having people know what the triggers might be. Here in Texas, we have had a horrifically hot summer. Heat is one of the #1 triggers. So it's very important for the kids, the families and the kids and the schools to know that that is going to be a very real thing for a lot of our kids going back to school. I know you guys, if for people up in the Northeast don't go back to school yet, we go back to school next week in Texas is the most frequent date that people are going back. And so because of that, it's still going to be quite hot. And that does become then a possibility to see more seizures because the kids are going to be outside for recess. Other things like lack of sleep obviously will be more affected at home, but at the same time, if they know like, hey, they had a bad night last night, then the teachers or whoever's with someone during the day can be more aware of what they should be looking for that day compared to others. The standard care is going to be that very basic seizure first aid that we talked about. Time the seizure, keep the person safe, keep them on their side, and don't restrict them. We'll go over that a little bit more in just a minute. This is the seizure action plan that we use in our office. And this one is made by the Epilepsy Foundation of America. And I will say a majority of schools also use this one because it kind of has all the information that you could need. One of the most important things that you want on the seizure action plan is not just the emergency contacts and the family's information of who to get in touch with if they were to have a seizure, but also the physician. And the reason that you want to make sure that the physician's name is on there is because if you don't have that and they end up in a hospital setting, they won't know who to call. And so we want to make sure that they get to the group that is most familiar with the patient's seizure types, with what we typically do after them, those types of things, because certain patients may respond better to emergency medications, to specific emergency medications versus others. You can see on here that it has different seizure types. We include the link, the frequency, and then a description. The reason we would like the description to be on there is just like we were talking about, that different seizures are going to look different. And I always say, when you've seen one seizure in one kid, you've seen one seizure in that kid. So people say, well, I've seen a seizure and I know that that's what they look like. But the reality is that seizures are going to look different in every single patient with epilepsy. And so because of that, we like to make sure that people know exactly what to look for in this setting. Knowing what someone is like after a seizure is also very important. We want to make sure that if they're going to complain of a headache, that they know that that's very typical for them. Most people are going to be very sleepy after a seizure. That's pretty common, especially after the larger convulsive events. And a lot of our patients will be able to take naps afterwards, and that's kind of written into their plan, whether it be at work, whether it be at school, where they kind of have some safe place to go. For a lot of our patients who work, whether it be for me, I'm a pediatric neurologist, so it's usually my late teenagers or my early young adult kids, so early 20s, then we will often ask that they be able to leave work. And so that can be something that's important when we're talking about what do these look like and what do you need in combination with this, is that sometimes you may need FMLA paperwork for them to be allowed to leave work when they have seizures. The basic first aid is always on all of this. It's exactly like we just talked about, and we'll talk about in a minute, a little bit further. They also ask, do they need to leave the classroom? And the reason for that is, for a lot of our children with more mild events like absence seizures or events without impaired awareness, they may be perfectly fine to stay in the classroom. They may not need to leave after, but we do want to make sure that somebody knows that it happened and is alerting the parents, which then goes down into the next part. So what do we do in those emergencies? What is the seizure emergency? And do we want them to call the school nurse? Do they need to call 911? If they do you have a preference for what hospital they go to? If they are obviously having a prolonged seizure, that is considered a medical emergency and they will go to the closest hospital. However, if not, and they're just being transported afterwards when they are what we call post-ictal or after a seizure, we want to know if there's a preference hospital. That's important for providers, because for us, we all have base hospitals that we work out of. And so it's not that I have any problem if they go to another hospital, but it's a lot easier if they go to my hospital. We also ask them to notify the parents and then to give the medications as it's described below. I always check notify doctor, but I will say on the whole, I don't get a lot of notifications. They typically go to the parents and then the parents will let us know. We often will put on there too, for some of our kids who have very frequent seizures, do not transport to a hospital unless. And that can become important because for a lot of families, having them constantly go to the ER, get exposed to all of the illnesses in the ER, especially in the winter, only to have them say, oh, okay, we'll call your neurologist. And it's like, well, yeah, we could have done that ourselves. And so for a lot of the families, then it becomes important for them not to go to the hospital or to call the parents. So we will also set that into the plans. If we have a really detailed plan from that standpoint, I will usually put it in letter form just to make it a little bit easier. So to walk somebody through, if it looks like this is what you're going to do. If the seizure looks like this is what you're going to do. And we have some families that don't want anyone other than the family member to administer the emergency medication, in which case we say that is absolutely fine. And then that is written into the seizure action plan. We're going to go through the different types of emergency medication options in a little bit, but you want to put down on there, are there emergency medications versus medications they may be taking every day in the middle of the day. Some of the medicines are dosed 3 times a day, and so because of that, they may be taking medicine in the middle of the day, which will be on there, versus an emergency medicine. So you want to make sure that you check off this box right here if it is an emergency medicine. And that would be, the most common ones are Diastat. They now make nasal sprays, or then tablets that you slide into the mouth. And those are the options kind of for that. Also on here, we have a vagus nerve stimulator. That is a device that gets implanted right here below the collarbone and sends a signal then up the vagus nerve. That can be activated by a magnet, and we like to remind people how to use the magnet. And so all you do is you'll take the magnet and swipe it, but that will always be checked so that people know that that is an option for treatment as well. I will say from our perspective, in terms of the special considerations, we will sometimes say, don't have them outside for too long, things like that, if we know that heat is a very big trigger, but we don't typically limit our patients because they have epilepsy. We instead say they can do anything that they would like, just keep them safe best we can. If your school happens to have a pool, which I know is not super common, but does happen, the one thing that we will put is during an outing in a pool, they do need to have somebody in the water with them at all times. And that's just part of basic seizure first aid and seizure precautions. When we talk about treatment options, it will be important if you've had a surgical treatment for your epilepsy. There are lots of different types of surgical treatments. And as you can see here, they kind of run the gamut of why we might do them. They can be curative, meaning we resected and now you're no longer having seizures, or palliative. And the most common of the palliative is what we call a callosotomy, where we actually just disconnect the two halves of the brain. And then what we do there is those help to keep the seizures from happening as often or spreading to become the large convulsive events, but yet they may still have very frequent seizures. They're just smaller. And so letting the people who are also helping care for your family member with epilepsy know if they've had surgery and what type it might be is very important. When we talk about the vagus nerve stimulator, I was just talking about that. It's a small device. The ones now are about this big, so about the size of one of those like Sacagawea dollar coins. If you've seen those, they are automatically programmed to go on and off throughout the day. So they're not actually responding to anything that's happening. They automatically go and give out electrical stimulation independent of what's happening during the day. They are able to be activated by a magnet. The magnets are large, about the size of a Fitbit watch, and just a magnet. They can wear them either on their wrist or on their belt. They come in that way automatically. And most kids or adults will actually wear one all the time. And then we do ask that the people who are caring for them or with them most often have one as well. A lot of parents have one that's connected to the backpack. They may have one that lives with the nurse. And you can always ask your physician for more magnets, or you can get in touch with Labiner, who is the makers of the device, and they will always send you more magnets if you happen to need them. I would say they only give you 2 when you first get it placed. And the reality is that most families, I would say, are probably at a half a dozen, if not more. I have them for when I go to epilepsy camp over the summer, and I find them in all sorts of different bags in our house when I'm packing to go on a different trip. The ketogenic diet is another treatment that's important for people to know if your child is on the ketogenic diet. Our main experience with it is in children. There are very few adults who are on a formal ketogenic diet. And the reason being is it's very, very, very difficult to maintain, especially if you are a high functioning adult, because it is incredibly strict. It's low carb, low protein, high fat. And so you literally, some of our kids are taking shots of MCT oil to keep their fat levels up. It is very, very, very restrictive. Everything needs to be weighed. Everything needs to be, we have to know exactly what the ratio of carbs to fat is in everything that they eat. And so because of that, then in a lot of settings, they may be bringing food, but the people who are helping to care for them will need to know that they can't eat other things. This is not, unfortunately, these are not the people who can have a piece of pizza after work because somebody wants to go out for it, or have a cupcake at the kids' birthday party in their classroom. And a lot of the parents, I will say, on our side will actually make them special cupcakes if they know that there's going to be a party or something of that nature, because you can make a cupcake that is in fact keto friendly. This is going to be the most severe version of the diets, or the most restrictive version of the diets. Some of our patients are also on a modified Atkins, which is kind of like the ketogenic light. So it is lower carbs, lower protein, higher fat, but with a little bit more wiggle room. So these are going to be patients who are, kind of eating in the lower carb, lower protein with the high fats, but they are going to be able to eat more fruit, eat some of the sweets that they may like, because while their ratios are going to be significantly lower in terms of their carb to fat ratios. So seizure first aid, the basics are really just this: time the event. The minute you get there, if it starts before you get there, that's okay. We know that no one is perfect. We're going to miss some of the starts of events, and that's all right. You're going to protect the head and body. If they are in a place where they could easily get injured, moving them, if you can, is very important. So for example, if you, are hiking and they're on the side of a cliff, we should probably try to move them over a little bit. Pools are an interesting one. We do recommend that if someone is in the pool and can stand with them, or in a body of water and stand with them, actually leaving them in the pool until it stops while holding them up and supporting their head up and out of the water, because you actually don't hit anything that could injure you in a pool, while you can imagine if someone is convulsing and trying to pull them out of a pool, it's quite difficult. However, if you are not in the pool with them and you see someone in water seizing, pull them out. And so you will never be wrong for taking somebody out of a pool. You want to loosen tight clothing as much as you can. Like we talked about, this is especially important around the neck. So loosening sweatshirts, loosening ties, unzipping things, loosening buttons if those are still there. Do not try to restrain them. You will not be successful in a convulsive event. They will seize past you, and you can actually end up hurting somebody more by trying to restrain them. There is an old wives' tale that you are supposed to put things in people's mouths because they may swallow their tongue. That is not true. If you let yourself and your tongue go completely limp, try to see if you can flop it around in your mouth. Well, the reality is we can't. Our tongues are very, very large muscles that are actually anchored to the bottom part of our mouths and our jaws. And so they actually will not flop back over your airway. The reason that people thought that was because you hear them gurgling and making choking sounds. Those are normal because they can't clear the secretions. That's why we want you to put them on their side. When you lay someone on their side, anything that's in their mouth is going to pool in the side that you've laid them on. And anything that's in the airway will not be into the lungs. Same if there's anything in their stomach or they happen to vomit during the seizure, which can happen, then they will not then vomit that up and have straight access to their lungs. You want to look to see if it's somebody that you don't know and you happen to come upon someone, to look to see if they have any identification tags that say that they have a medical condition. These are usually on the wrist or around the neck, so like a necklace or something like that. However, some of my patients are not the best at wearing those like they should. The other place to look is if they happen to have a watch band on, especially now with like the Apple watches and the Samsung watches, they make these little kind of tags that slide over the band. That may be there as well. People will often have this as part of their phone information too. If they look up their like kind of emergency contacts or ICE information, then that can also be on there. And so you may want to look there as well. This is one of my favorite ones. It is actually from the Epilepsy Foundation of Australia, because I think that the pictures are really nice in terms of just reminding you, you're there with them. You want to stay behind the person more than you want to try to pull them towards you. A lot of people are quite strong during their seizures. And so we talk about like dead weight when people pass out. During seizures, they get kind of Hulk strength. So it's a bit of the opposite. They will likely be stronger than you, even though they may not be in their regular everyday. And so if you can stay behind them, then you allow them not to fall back onto their back where they could aspirate or take in something into the lungs, and then have them turned on their side. You'll see down here on the bottom, this is what we call the rescue position. If you go through CPR training or anything like that, they will talk about the rescue position on there. And that is just that they have their knee bent, their arms here, and that will also help keep them propped up after the seizure has ended, so that they, again, any drool, anything in their mouths will come out. When do you call 911? That's the number one question we get. A, do I have to call 911 every time? The answer is absolutely not, especially if you have seen many of them. However, 911 is there for any time you are uncomfortable. We recommend any time that a person turns blue or purple during a seizure, whether it's 30 seconds in or 3 minutes in, you want to call 911. If the seizure hits 5 minutes, you want to call 911. The first time you use rescue medication, I also recommend calling 911. And the reason is because some people can have less respiratory drive after those medications. And so we recommend having somebody with oxygen coming the first time just in case. In a prolonged seizure, and those seizures are defined as seizures lasting 5 minutes or longer, you're initially going to stabilize them with seizure first aid. We recommend the use of emergency medications in seizures lasting 5 minutes or longer. There are people who will use them at 3 minutes. 5 minutes is a definition from the American Epilepsy Society and the International League Against Epilepsy as a definition of a prolonged seizure. It used to be 15 way back in the day, but what we know is that most seizures will end on their own in 5 minutes or less, which is why we use that 5-minute mark. And so it's not totally random. I will say if you give medication early, no one will ever fault you. There are lots of different options when we talk about emergency rescue medications. Diastat is probably one of the oldest ones that's been around for a very long time. It is a rectal gel, and these are all benzodiazepines. All of the abortive medications are from the same family of drugs. So it is a rectal gel. I have a picture on how to use it, and that actually comes with every single kit of Diastat. There's been a lot of movement away from Diastat recently as other options became available, specifically the nasal sprays, which we'll also talk about. Klonopin or clonazepam is also used. They'll use a lot more in the cluster seizures. So for example, our absence kids or people with myoclonic seizures where they can cluster, and we know if those clusters consolidate and they have a lot of them in a row, then they could become a larger convulsive event. Then that will often be administered to the patient by themselves, that they can actually do it, but they may have an oral dissolving tablet as well. There's also nasal Versed, which you will see some of the ambulances like to use. Nasalam and Valtoco are the two medications that are commercially available. And then inside the hospital, we will frequently use Ativan or IV lorazepam. That can also be given as an injection, but that's going to be most common in the hospital space. So when you use Diastat, I will say as someone who has used it, it is one of my least favorite things on the planet to use. And that is the other reason we've really moved away from it. Now, I have some patients that it is hands down the most effective abortive treatment for them, which means that's the one we use, even though it is not pleasant. And what you do is it will be locked to the appropriate dose. So the most important thing is that when you push and you push it in, if it does not go all the way to the top part of the syringe, that's okay. There's an intentional lock there to not give all of that medication. The hardest part is it's messy. It's messy for you and it's messy for the patient. That's one of the other reasons. It's also very invasive in comparison to a lot of the other medications that we now use in kids for rescue therapy. The nasal sprays are mostly now available in the ages of 6 and up. However, we are sometimes able to get them for younger kids. They are single-use sprays, 2 different ones. The 2 different brands are 2 different types of medication, but both benzodiazepines. What you do is you actually put it into the nose, push that little button right there, and it will spray up into the nose automatically. They work very, very quickly. Our faces are incredibly vascular, so you get good absorption of the medication. And usually we say will work within 3 minutes or less. I will say I think they tend to work faster in my personal experience. The difference in terms of which one we use is often dependent on which one we know a patient will respond better to. And sadly, the worst answer is that sometimes it's dependent on your insurance company and which one they are willing to pay for. You will also sometimes hear atomized midazolam being used. What that is going to be this little picture down here, which is actually a regular syringe like you would give for an injection, and you draw up the Versed, put the atomizer on top of it, and that will spray as you push the syringe. So a little bit different, but the same concept. For years, if you wanted a nasal option, this was the only one available, but now these are commercially available. They are one-time use, so once you use it once, you throw it away, and that's it. If you have to give more than 1 dose of the nasal sprays, you want to give it in the other nostril. And we will always, I always write that, I say we, but I always put that on mine, but I know other people don't always think about that part if you're only typically using 1 dose. But that is something to think about. If you needed to go to the other nose for a second dose, you want to give it in the other nostril. Does not matter which one you give it in, unless there is a reason why one is not. So like, for example, if you've had a big surgery or something on one, that's probably not the one you want to use first. Klonopin is the tablets I was talking about. So we have the oral dissolving tablets. Those are going to be the most often ones that may be used by somebody else. Clonazepam is quite convenient because it comes in its own little tear pack. So each individual tablet is going to be individually packaged. That makes it very easy for a parent to put them in their wallets, for people to travel with them. And all you do is you open that one and you're going to slide it. Remember, the patient will be on their side. You slide it in between the cheek and the teeth, which whichever side happens to be up. I always recommend whatever side is up because the other side may have a lot of drool, which means it's not going to be absorbed as easily. And then I recommend taking your finger, sliding the tablet in there, and then actually rubbing the cheek. And the reason you want to rub the cheek is actually to help break the pill down a little bit. Every now and then we have a patient who doesn't have the oral dissolving tablets and will have the regular tablets. Those ones you will have to kind of crush a little bit before you put them in or rub them for sure, because that'll be the only way that they'll break down. And that is all I have. So this is my little boy. I adopted him. And the reason I put him on all of my epilepsy slides is because I adopted him not knowing that he had epilepsy. So he had his first seizure at 4 months of age. And now we have actually multiple of the rescue options in our house and give medication twice a day, every day, so that he doesn't have his seizures. So I always like to say I do this at home and at work.
I'm sure he's lucky to have you, Kate. Okay, Dr. Labiner, thank you again so much for all the information that you were able to share with today's attendees. We do have some really specific questions coming in, some very specific questions that were privately messaged. I do want to stress that Dr. Labiner is here giving very general information and guidance. I'm sure she's going to have to ask many more questions and have, a great history and background in regards to your medical conditions to be able to answer some of the questions. With that being said, I do want to get to some of the general questions if we can.
Absolutely.
Perfect. So can you talk a little bit more about if someone is having a seizure, if they have fluid in their mouth? You mentioned to turn them to their side. Would you keep someone on their side throughout the duration of the seizure or allow them to lay back down?
So we recommend keeping them on their side the entire seizure. And the reason being is that if it pools here, that's okay. When they're on their back, and I will say in all of the large convulsive events I've seen, the very first thing everybody does when they come out of it is go, and that is a large, deep breath in. People are still breathing during seizures. Your lungs are actually still working and the oxygen is going back and forth. That's why people can seize for prolonged periods of time and actually not turn blue during their seizures. But what they're not doing is having that nice coordinated breathing that you normally get. So they'll start that nice coordinated breathing. If they roll back onto their backs during the seizure, then it can pool in the back of their throat, and then it'll go straight down into their lungs if they take a big deep breath in. And so that's why we recommend leaving them on their sides. The other thing is that some people will have vomiting right after a seizure. It's a very common thing that we see, especially in children, that they'll just vomit anything that's in their stomach, and we don't want them to accidentally choke on that either.
Dr. Labiner, can you talk a little bit more about some of the other medical devices that you've seen someone wear, such as the ID bracelets, things that would alert someone that someone has seizures?
Yeah, so the most common one is going to be the kind of classic ID bracelets. Although I will say now on Etsy, they have lovely, very pretty ones. And that is where I see a lot of especially my teenage girls, getting theirs from, because the reality is that the old ones are not that attractive. And so what they are and the information you want to put on there, because you don't have a lot of space. And that is one of the kind of key things, is that there isn't a lot of space on those. And so what you'll see is it usually will say medical alert on one side with the caduceus on it or something of that nature, or the large, you'll see like a red cross, something like that. And then if you flip it over, it'll say epilepsy, and then usually give the number of a person to call. Now, for some of our kids, they'll wear the necklaces, and it's almost like a dog tag of sorts, and you can put a fair amount of information on that one. So like one of my patients who's going to college, they have his parents' number, his brother's number, his dorm, and his room number on there so that someone would know kind of where he might have been headed when he had the seizure, or where they could go to get help, because that's where his roommates would be and where his emergency medicine would be. So those are two of the kind of most classic ones. The other thing to look for with the ones that will slide on, and even now some of the necklaces will have QR codes on them. And the QR codes are really interesting because you can scan them and it pops up exactly what to do, including, do you have a device? Do you have medicines on you? All of that information. And I will say, even for my little boy here, I actually have one for him that is on his collar, so that if someone was to scan it, I actually know that they've scanned it. It sends me an alert as well, and tells them that he has epilepsy and has to take meds twice a day.
Great idea. I have seen in situations, occasionally people with intellectual developmental disabilities may have a lot of heightened sensory issues. I've actually seen someone who was able to have a tag laced through the shoelaces of someone's shoe. So again, there are options out there. If you need more suggestions, please feel free to reach out. We'd be happy to provide that information for you. Dr. Labiner, can you go back to the slide that spoke about the absent and atonic seizures?
Yes.
Someone's just asking for another brief overview between the two, if you could.
Hold on, we did not get it quite right. Yes. Okay. Yeah, no, that's actually a great question, because I can see. So in a tonic seizure, these are drop seizures. These are going to be most common in very young kids. And kind of one of the classic examples is actually head drop events. And so the kids will just be sitting there and that's it. And it's very quick, lasts only a handful of seconds at the most, usually fractions of a second. If they are older and standing, you'll actually just see them fall. Very rapid, very quick. Sometimes they'll be told to us of like, it almost looks like they passed out, but it was so fast. They tend to go down a lot harder than when people pass out. When you see someone pass out from, lack of blood flow to the brain or something like that, you kind of see like the wilting type effect, right? Where someone kind of collapses slowly. These are very quick, very sudden, quick movements. So either it just looks like the legs go out. They actually don't really ever go to the sides. Either it's kind of straight down. The heads are the most problematic ones. If you see people with helmets on, that's often because they have drop seizures and they're there to protect their heads because they whack their foreheads on things so often. These are actually highly problematic because they are very damaging to the teeth. Because you can imagine it's hard for us to protect someone's mouth all of the time. And so they can whack their mouths on desks, on tables, things like that. And these are seen, they're kind of one of the classic seizure types for Lennox-Gastaut syndrome, which is one of the refractory or very difficult to treat epilepsy syndromes. And then infantile spasms, which we see all the time in the peds population, but are not seen, probably kind of obviously based on their name, in the adult populations. But you can have epileptic spasms. Those tend to look a little different. Absent seizures are actually very fascinating to us because the entire brain is involved all at one time, yet people don't typically fall. They will not typically hurt themselves during it. It's actually fascinating. A lot of the primitive reflexes remain intact during them. So they will actually swallow if there's something in their mouth, like they're chewing. I've seen patients continue to chew and then swallow during a seizure, but I have them on EEG, so I know they're seizing. And those types of things that will happen during an absent seizure, and they literally just pause what they're doing, but we don't expect them to fall, to hurt themselves, anything like that. The times when they could hurt themselves, as you can imagine, if you paused walking downstairs and you were kind of shifted forward, you could fall down the stairs, but they won't hurt themselves because the body typically does not lose tone. So they stay completely intact, sitting or standing.
Wonderful, thank you. Lisa, if you're available to unmute and go on camera, if you're comfortable, we would love to have you back on with us. Hi there. Lisa, we actually have a couple of questions I think that you may be able to assist with. I do see that you offered some information about Epilepsy Alliance America having a program for the seizure ID products for the QR code. You want to talk about that?
Yep. So I will send this. You'll get this and follow up from Melanie because I've been writing my follow-up notes to send to her while we've been chatting along. But Epilepsy Alliance America, I did put the link in the chat, does have a program where we will give a $35 coupon for a company called getmyid.com. And they make exactly those products that Dr. Labiner was talking about. They make bracelets with QR codes, the slides for a watch with QR codes, the tags for your backpack, or you could put on your shoe. I love that idea with the QR code. There's a grant that we still have through one of our pharmaceutical partners. So we're still able to offer these coupons for people, and I'd love to give them away. So just request one and you'll get a coupon code by the end of the day. And then you can go shopping there. Two other things that I'm, go on.
Oh, I was going to say the other option too is that there are also grants available through a lot of the partner groups. So the Danny Did Foundation gives out lots of grants every single year, and they're a great resource for people who maybe, because we recognize that for some families, $35 is still a lot of money. And so for them, they will actually help pay for those types of things. It's just a form, you fill it out, and they do a lot of grants for that.
Yeah, and actually, Danny Did was our presenter for the first webinar in this series on seizure detection devices. Secondly, Dr. Labiner did a great job talking about the emergency and rescue meds. One of the other follow-up pieces will be, we have a video series in English and Spanish that actually walks through the administration of each of those medications that she walked through today, so that you can watch those on YouTube and have them available and share them with caregivers as needed. And lastly, I know some questions also came through regarding whether you're at a facility or a school that wants to have a training for people live and in person. And I'm happy to connect anyone with one of our member organizations if there's one available. Because each of our member organizations have personnel on the ground who can go and partner with you to do those trainings in person if needed and appropriate and requested. So we're happy to do that.
And most of the epilepsy foundations will also be happy to do that for you. So if you don't happen to have one of those Epilepsy Alliance partners nearby, you can also contact your local epilepsy foundation. There is one for every single region here in Texas. We're a bit of an anomaly because the state is so big. We have 3. And so they will absolutely send someone to wherever you are, including for us. We've done them as far, I know the Epilepsy Foundation has done them as far as down into the valley, which is about 4 hours from where I am right now, but yet still part of mine. And so we do that. And then we also will do it for school groups. And so we've had patients who have asked, and then we've gotten in touch with the school nurses, and the school nurses for all the districts typically do training over the summer, right before the year starts. And a lot of places are happy to send one of the nurses to come do it for them live. Our nurses do it all the time in the office for families. And so we actually typically will send either one of our nurse practitioners or one of our nurses out to go do that training live for them if they ask for it.
Wonderful. And Lisa, can you drop your contact information in the chat also?
I can do that, yes.
I know a majority of today's attendees are from New Jersey, and New Jersey does have an epilepsy foundation, but I would like, if you're comfortable, Lisa, for people to reach out to you directly for that information and guidance in regards to who to reach out to for training.
Absolutely.
Perfect. I know we have a lot of people also asking about the PowerPoint. There is a link to the PowerPoint in the chat section. If for some reason you cannot access the PowerPoint using that link, please know that by Monday at the latest, we're hoping before, that a copy of the PowerPoint along with today's recordings, and Lisa is incredible about sending me resources to attach to that email. You're going to get a lot of information in that follow-up email. So please make sure to keep an eye out for that. It may come from the Community Living Education project or me directly, Melanie McGackin. I'm not sure what name the email is going to show up under, but make sure that you keep an eye out for that, and you'll be able to access a recording of this webinar and all the resources shared. Dr. Labiner, I do see another question in the chat. within the chat section, it does say with the RNS is a magnet needed as well.
That is a great question. And so the answer is actually no. So the RNS is different than this. And that's actually the reason I didn't put it in here, is because you don't need a magnet. So the RNS has an EEG strip that's actually placed onto the brain. And then we train the device what to look for. And then it responds specifically to the pattern that we've told it to be looking out for. Because of that, then it does not. There is a magnet, however, to activate a longer recording. And so parents and family members will typically have that, but it will automatically do that all on its own. And so it does have a magnet that you can kind of swipe if you think that something may happen, or if you're not sure if something happened. Because they fire, the magnet is more to put a little mark that's like, hey, we were worried that they may have had a little bit of a seizure here, but we didn't see a full convulsive event. Was that the start of a seizure or part of a seizure that the RNS then responded to and stopped? And so because of that, they do have magnets, but they're not to activate them.
Great. And I'm not sure if you are comfortable answering this, but we do have someone
Okay.
who's asking, does medical marijuana help with seizure activity? And if so, can you share a little bit about that for people to explore further?
Absolutely. So I'm actually happy to talk about that. It is absolutely one of the options. I always remind people that it really does, CBD, for me, goes on the list of all the other medications. It is absolutely an option. But for every patient that believes that CBD was a miracle drug, there's a family out there who feels that Keppra or Onfi or Tegretol were the miracle drug for them. And so it is an option like everything else. There are different options available based on where you live. So Epidiolex is cannabidiol only. There's no THC in it. That is FDA approved and actually available through the pharmacies. Your insurance company will pay for that one. For that one, you do have to have a very specific epilepsy kind of pattern. It needs to be refractory, meaning that you've failed multiple other medications. And so that would be one to talk to your doctor about. In other states, here in Texas, for example, we have what's called compassionate cultivation, which does allow then for the use of CBD and THC combinations to be used when you are put into the registry. And so that is at the discretion of your physician. For us, it is actually only available to neurology, pain management, oncology, and somebody else. And we put the patients into a registry, and then we're in a registry, and we actually write a prescription. It comes from a mandated pharmacy, and from a mandated, I think they don't call them a pharmacy, it's called a dispensary. There we go. But it is controlled by the state. Quite a few states who allow for the medical use of marijuana have that type of system, or places where they're getting it from, where we know what we're getting and kind of what it's going to look like. I say, like anything, it's worth trying it, but you have to be open and honest with your physician if you're doing any of the online ones. There are some very well-known online providers. Charlotte's Web and Haley's Hope are probably two of the ones that have been around the longest. They are very, very well known, and they are absolutely available. They ship all over the country. Charlotte's Web is based in Colorado. Jaden's Juice is one that's based in California, but I don't believe ships outside of the state of California. And so those ones are also available, but we need to know because they do interact with some of the other medications. So for example, they may change the metabolism of the medicines that you're already on. And that's why it's important for us to know if you are using any of the hemp supplements or CBD supplements that may not be provided through your doctor as a prescription.
Thank you again.
Yeah.
So we have someone sharing that they're asking if a person is having a seizure while standing and rocking back and forth slowly as though a slow dance, is it an absent seizure? This person is not falling, but occasionally banging into things and making vocalizations, was previously diagnosed with tonic-clonic. Again, I would strongly suggest that you reach out to your medical professional for that. But Dr. Labiner, I don't know if you had any additional guidance.
Yeah, so So we can see in the focal seizures that you may not fall down. We do absolutely have patients. I just saw one this morning who can still walk during their seizures and can kind of guide themselves to safety because only one part of the brain is seizing as opposed to the whole brain the entire time. You may also see changes once somebody starts medication where they may not fall anymore, but yet they may become very unsteady. They may have that sensation like they're dizzy, but yet it may not look exactly the same like it did before. And so it may fall into more of the partial seizure or focal seizure category versus an absence. Hard to know without an EEG.
Let's see, I did see one more question that went through the chat. You have any suggestions for individuals who experience nocturnal seizures? And also, and I greatly apologize, I am not familiar with the word catamenial.
Catamenial,
Epilepsy.
Yes. So nocturnal seizures are very difficult because they are at night. And that's actually one of the things we always ask patients, like, do you ever find yourself on the floor? Do you ever wake up and you're confused as to how you got to where you are? Do you wake up bruised and you don't know how that happened? And those can happen because people are seizing at night and don't know. So we do recommend that you wear like the watches that will alert. So the Embrace watch is the one that is FDA approved, but there are multiple apps that can be downloaded onto the smartwatches that will do the same thing. And what they are is seizure detection devices that can be used at night. And so those are the things that we recommend for people with nocturnal seizures, so that if it goes off, it will alert someone. I will say we definitely see people who don't find out that they're having nocturnal seizures until they have a bed partner and somebody is like, hey, you know that you shake a lot at night and it's real weird, and then it stops and it only lasts a couple of minutes. And so those are the things that we recommend. You will see that there are things like bed alarms. They tend to go off a lot, and they tend to go off a lot for things that aren't seizures. So we actually don't recommend the use of the bed alarms very much, mostly because they're more annoying than they are helpful. So the watches and those types of devices are probably the best options. For the little kids, they have an owlet, which is actually used as one of the SIDS protection devices. And a lot of our parents will use those as their detection device. I also recommend that for anyone with nocturnal seizures, especially if you have a teenager, we like to still give them their independence and their freedom. Use a baby monitor. Just put a baby monitor in the room. You're going to hear it if they start seizing, especially some of the big convulsive events. You'll hear that, but at the same time, then you don't have to be in the room with them all the time. Yeah. And the second part was catamenial epilepsy. So catamenial epilepsy is epilepsy that is tied into the swings in your hormones. This is most problematic in women who have cycles that are monthly. When it comes to that, it really does depend on the person and kind of what they're interested in terms of their treatment. I absolutely have patients who change their medication dosing during those times, where they'll go up for a week and then come back down, or they may take their like a clonazepam schedule during their cycles when they wouldn't normally do that. But one of the other things that we often will recommend is actually hormone regulation. And so reducing the number of cycles that you have, so you've reduced the trigger. So much like we tell patients, get enough sleep, right? We know the lack of sleep is the trigger. If you get enough sleep, not a problem. If you can stop the hormonal swings, you don't trigger the seizures, and then can help on that as well.
Wonderful, thank you. And I did just put in a chat section. Last month, I believe it was, we did our first part of this series with the Danny Did Foundation. Yeah. So I did put it in chat section, and that was on sudden unexpected death in epilepsy and the use of seizure detection devices. I know both Lisa and Dr. Labiner have mentioned the Danny Did Foundation, whether that is for grant purposes or information. So I did put a link to that webinar. So please feel free to copy and paste that. You can also find that link on the Community Living Education Project through Rutgers University on our website under webinars. Lisa, Dr. Labiner, do you have any final comments you would like to share?
No, I do not.
Thank you so much.
Wonderful.
I learned a lot.
So thank you. And for everyone joining us today, again, thank you so much for taking the time to share in today's presentation. Dr. Labiner, again, your information greatly valuable to many. For everyone you joined today, please know that we are going to send a copy of the PowerPoint, the resources, and a recording of this webinar to your email that you registered with. You'll have that by early next week at the latest. As we're preparing to say goodbye, you're going to see a brief survey pop up on your screen. It takes about 30 seconds to do. It's the information that you provide us. It allows us to really to tailor future sessions to better meet your needs. So we would encourage everyone to do that. If you would do so, it would be greatly appreciated. Lisa, Dr. Labiner, thank you so much. And we look forward to next month's presentation. So please look for that outreach email so you can register for the next session if you haven't done so already. Please be well and have a good day, everyone.
Thank you.
Thank you.